Shoulder pain is bad. So bad, in fact, that over the last 40 years, there has been no real agreement on the names of the different types of shoulder pain, the best treatment for the different types of shoulder pain, and even the most accurate ways of diagnosing the different types of shoulder pain. So if the clinicians haven't got a clue, then what chance have you got with your shoulder pain? Thankfully, though, after 40 years of throwing scientific spaghetti at the wall, we now have a lot of evidence that allows us to create simple and accurate diagnosis for different types of shoulder pain. Hi, my name is Paul, pain therapist here at Fizzi, and welcome to my summer kitchen here in Sicily. The sun is shining and I have my espresso at hand, and today we are going to be talking specifically about non-traumatic shoulder related pain. And this means that it is a shoulder pain that was caused unexpectedly. You did not fall over, there was no trauma, there was no clear cause of injury, and yet you have shoulder pain, so you are unsure of its origin. So there are 6 common types of shoulder pain that we are going to cover today. The first one is rotator cuff related shoulder pain. Then we are going to talk about bicep related shoulder pain. Then we're going to discuss AC joint related shoulder pain or acromioclavicular joint related shoulder pain, labral pathology related shoulder pain, glenohumeral joint related shoulder pain, your shoulder joint, and finally adhesive capsulitis related pain or frozen shoulder. So let me just have a drink and let's begin. So what I'm going to do is I'm going to discuss each type of shoulder pain and explain to you how it can be accurately diagnosed with a few simple questions and simple tests that can be done in clinic or at home. And then we will touch on some of the most effective treatment options available out there today. Number 1 is rotator cuff related shoulder pain, which actually encompasses several types of shoulder pain you may have heard of or have been told before, which includes rotator cuff tendinopathy from any of the muscles, rotator cuff full or partial tear, and then finally shoulder impingement syndrome. And the reason that I have clubbed these all together is because this is what all clinicians should be doing now, and the reasons are simple. Shoulder impingement syndrome is shown to be a fear-inducing name. So people who think that they have a shoulder impingement, they then assume that there is something mechanically wrong with their shoulder, and the only way to fix it is with surgery. We know this is not true. Theory is that the bicep tendon has become very thick on certain individuals, maybe through inflammation or just through natural genetics, and it creates friction in the shoulder joint as it moves. Therefore, you need a surgery to trim this down and allow the shoulder to move freely. But we now know after 40 years that there is no difference in pain from people who have the surgery and those who do not. So therefore, we can discount that as a cause of pain, and therefore the name is redundant. Secondly, with a rotator cuff related tear, whether it is full or partial, we know now that most people will go through their lives and have full or partial tears, and they will be asymptomatic, meaning it will not cause them any pain. So therefore, we can also not use the fact that you have a rotator cuff tear on MRI as a reason for your pain. Finally, tendon pain can be difficult to gather on imaging, and it is just easier to just say rotator cuff related pain, because any individual could actually have any of the symptoms that we have just discussed there. So a more umbrella term like rotator cuff related pain is much more appropriate. And to diagnose this is very easy. What you will see is pain on the front and side of the shoulder, and most likely you will have a restriction in your active movement. So you will not be able to move your shoulder all the way up or all the way out to the side. You will, however, be able to do this passively. If you get some additional help, you can still get it up there. So you still have full range in the joint, but the muscles are limiting you. You will also have weakness and pain when performing muscle testing. This can be done in positions like this, pushing out against yourself, or it can be done with weight and trying to lift weight, and you will notice that that will replicate your pain. That is it. Bicep tendon related pain is as it sounds. It is pain in your shoulder coming from the bicep muscle. The bicep has 2 tendons, and one of them is very long and comes all the way up here into the top of the shoulder, and something that we call the bicipital groove, as it sits in a groove within your shoulder. To diagnose this type of shoulder pain, you will have again pain up at the front of your shoulder here, but the difference is in how we can replicate that pain. The first is by finding that bicep tendon on the top of your shoulder here and moving it along. Tendon structures feel quite fibrous and thick, and you will feel a lot of irritation in this area. when you press on it. The second one is by testing the bicep muscle itself, and if that reproduces your pain, then you know that the pain is coming from that region. So you can perform bicep curls and see if that hurts, or equally, you can just put your hand out in this position and press down. The other test that is commonly used is your hand is out straight and you try and push it down from the wrist, keeping your elbow straight. If these replicate your pain, then you know it's coming from your bicep. AC joint related shoulder pain, or acromioclavicular joint, is pain coming from that joint itself, which sits here at the front of your shoulder as it connects from your collarbone into your shoulder joint here. So again, palpating on this area will help, as you basically, all you have to do is just follow your collarbone all the way along until you feel a dip. Where that dip is, that's where it is connecting to your shoulder joint, to your acromion, and that is the AC joint. If that's sore, the next thing you want to do is bring your arm across your chest as if you're trying to pat yourself on the back. This will compress the AC joint and again should likely replicate your pain. In severe cases, you will actually see a big bulge and swelling around the AC joint. All you have to do is just compare either side. The labrum is one of the connective tissues that helps keep the shoulder joint in place. The shoulder is very famous for being prone to dislocation, so you are only likely to have a labral injury if you play an overhead sport where you do a lot of throwing or racket sports, or equally if you are performing a lot of manual labor all day, every day. What you need to do is you need to get someone to put your arm in this position. You are out in abduction, the arm is out to the side. Someone will take this elbow fixed, hold their hand there, and put your hand out there. And your job is to keep it there once they let go. If your arm falls in like so, that means that the labrum is not doing what it's supposed to be doing, and your shoulder joint has become unstable. In most cases, this is an asymptomatic injury and very common with people, and will not likely require any surgical intervention as long as it is just a shoulder related pain and not from any trauma. For osteoarthritis related joint pain, or glenohumeral shoulder pain, what we're looking for here is a pattern. We're looking for people who are over the age of 50 and express a lot of stiffness in the shoulder joint, particularly in the morning, which eases off after about 30 minutes and also responds very, very well to anti-inflammatory drugs, ibuprofen, and heat and things like that. What you'll also find is that not only do you have a restriction in movement and in strength, but you have a restriction in the passive movement in the shoulder joint, which I will show you, which I'm showing you right now how to test at the door frame. And you will notice that you can feel a restriction in the movement, and this is because the shoulder joint is causing that restriction in movement rather than the muscles, and that is how we dissociate from that. And the final shoulder pain we're going to talk about today is frozen shoulder, or to give it its medical name, adhesive capsulitis. The difference between this and glenohumeral osteoarthritis is that glenohumeral joint arthritis is considered a progressive disease that can be maintained and managed throughout the rest of your time, and most likely not going to cause you too much discomfort. And adhesive capsulitis is something that will actually go away after a period of time. The key difference between the two of them is the pattern. So with adhesive capsulitis, what you'll notice initially is stiffness and restriction of movement, but not a lot of pain. Then as things progress, you'll notice that the pain really, really spikes up and your shoulder can barely move whatsoever. The key sign when testing for this at home or in clinic is external rotation. If it feels like the external rotation is hitting a brick wall and there is no budge or no movement in it whatsoever, and that also causes a lot of pain in yourself as a patient, and that's a good sign that you have adhesive capsulitis. But bear in mind that it is only really common in people who have diabetes or hypothyroidism. It is a much rarer condition outside of that. Incidence rates with people who have those diseases are as high as 20%, and incidence rates anyone without hypothyroidism or diabetes is as low as 3%. For the first four pains, rotator cuff related, bicep, AC joint, and labral, you will probably see significant improvements in pain and function within 3 months by just going through general treatment, which could be through your GP, your physio, or whoever. You will get a mixture of medications, painkillers, stretches, exercises, and manual therapies, and over time you will start to see a gradual improvement. With the other two, however, the treatment process can be a little bit more complicated. Adhesive capsulitis, or frozen shoulder, can last anywhere from 12 months to 36 months and follows a very distinct pattern of gradual stiffness but low pain, and then maximum stiffness, very high pain, and then it gradually thaws down in stiffness and the pain comes down slowly after it. People experience it through different speeds at different paces. The main treatments that help can be steroid injections, eccentric exercises, and potential soft tissue massage on the muscles in and around, and just general management, and having a therapist to go see regularly so you can talk about it, and making sure that you can make adjustments for work, and just knowing that eventually it is going to clear up. With glenohumeral joint osteoarthritis, it is more of a management plan process. Exercises, stretches, strength training, diet, weight management, and making sure that you're keeping as active and as healthy as possible is going to help you there. But this is an ongoing process. Now let's look at a skeleton treatment plan that could help with all of the injuries we have talked about. Strength exercise is definitely the best one for many reasons, because whether your pain is coming from the muscles or the joint, building new muscle tissue is going to help make that joint stronger. You're going to constantly build up your exercise capacity, which is going to reduce your pain threshold. And also, we know that exercising releases endorphins in the body, which help to reduce our pain perception. So basically, we feel less pain. And a lot of time, it can actually help reduce inflammation in our joints because the joints are moving and they're moving around the synovial fluid. So strength exercises is the best way to start. And I would always go with concentric movements. And for anything in the shoulder, you have to be thinking external rotation, elevation, push exercise, and a pull exercise. If you can do these things, whether it is at home, in the gym, with dumbbells, with resistance bands, with machines, then you're off to a very good start. The next thing that I would move on to, if that's not helping and the pain isn't reducing, I would move on to eccentric exercises. The reason being is because they put a lot less strain on the joint and then the muscles, and they often evoke less pain. The trade-off is, though, however, is that they don't develop the muscle architecture enough, so you don't build as much new tissue, and you don't gain as much strength. However, if concentric exercises and traditional strengthening is causing too much pain, you would then move back to this one and follow the same process. The way it works is that you control the movement as the muscle lengthens. So the example for the bicep would actually be that you start up here and you control on the way down and lengthen. And that is one, as opposed to up and down and going through the full range. You only focus on that movement. If after 6 months with all of this exercise training, you're still not seeing any real improvement, then that's when I would consider consulting a specialist to get a steroid injection directly into the pain site. This can be a great way to reduce pain for a period of 3 weeks to 3 months, depending on the individual. And during that time, you can really work on building up the strength, doing the concentric exercises that we spoke about initially. If you're 1 year down the line and your shoulder pain has still not improved, no matter which one it is, then this is where we have to probably bring in a surgical consultant to see what they think the best thing to do would be. For all the sources of shoulder pain discussed in this video, it's always recommended that you discuss it with your doctor, with your physiotherapist, and with a professional, so that you know exactly what you can do and cannot do. So what have we learned today? We've learned today that most shoulder pain is either coming from your rotator cuff, which helps support the shoulder joint, the bicep muscle, your AC joint, your labral in your shoulder, your glenohumeral joint, or your joint capsule. And depending on your story, situation, and with a few key physical tests, it's very clear to see which type of pain you have, what diagnosis to give, and how best to move forward. And this is so great because once we are clear on the what happened, the why it happened, and how it happened, we can move on to the treatment, and it becomes much easier and much more effective. Speaking of treatment, if you want to check out this week's newsletter, I am going to be releasing my home shoulder rehab program that can help reduce pain and improve function in all types of shoulder pain. It is great for beginners. It is a home-focused workout. You can get creative. You can use anything. There is minimal equipment required. The newsletter is free. You're going to get a lot more in-depth information. Plus, you get a free poster, which I call Simple Health, which shows you what you should be eating and how much you should be exercising per week. So that's everything in today's video, guys. Thanks so much for joining me, and I will see you in the next one.